Welcome, everyone. Thank you for all of those that have joined us today. We really appreciate your time. My name is Dr. Michael Blaivas, and I will be hosting the presentation today where we will share some information about developments in quality and standardization of ultrasound training in obstetrics and gynecology, along with our co-host, Dr. Alfred Abuhamad. You are in listen mode only, which means that no one will be able to hear you if there's noise in the background or you decide to chew gum or anything like that. But you will be able to hear the presentation, hopefully without any difficulty. If you have any questions while we are waiting, you can write these questions down in a question or chat box that's found on the right side of the screen. You can type in any messages there and we will address them in the latter half of the webinar. As we get started, we'll briefly cover the three main goals or topics of the presentation for today. They include obtaining insights from the American Institute of Ultrasound and Medicine Beyond Ultrasound First Forum, which occurred this past Halloween in Boston and was attended by dignitaries and representatives from all around the world, in fact. The second goal is to discuss the future of competency assessment and performance tracking. And lastly, to better understand the implementation of education in residency training, including actually training the trainers and assuring consistency in the curriculum. First, let me tell you a little bit about myself and my medical background. Again, my name is Mike Blaivas, and I trained as an emergency physician, followed by a one-year fellowship in emergency ultrasound. My interest in point-of-care ultrasound started back in 1993, and since that time I've had the great fortune of working with some of the preeminent researchers in ultrasound, publishing a lot myself, and being a member or president of several ultrasound societies, both domestically in the United States and internationally. More importantly, I'd like to introduce today's co-host, Dr. Alfred Abuhamad, and I'll let him give a brief introduction about himself.
Thank you, Michael. Good morning, everybody, and good afternoon to some of you also, and happy Thanksgiving. My name is Alfred Abuhamad. I'm currently the chair of the Department of OB-GYN and the Vice Dean for Clinical Affairs at Eastern Virginia Medical School. I've been involved in OB-GYN ultrasound for more than 25 years, and I'm actively currently involved with several societies with regards to training of OB-GYN ultrasound. I am the past president of the American Institute of Ultrasound and Medicine and the president-elect of the Society of Maternal Fetal Medicine. I was also asked and had the privilege of chairing the recent task force by the American Institute of Ultrasound and Medicine on curriculum development and competency assessment of ultrasound in residency training, both in OB-GYN and radiology, and I'm very happy that we will be discussing this today. Thank you, everybody.
Very much, Dr. Abuhamad. At this point, let's begin the session. Our first question is, what is the current ultrasound utilization in obstetrics in the United States?
So that's an important question because I think it shows how widely used ultrasound is in obstetrics and prenatal care in the United States. We don't know the exact utilization numbers, but several years back, about 3 years ago, myself along with Dr. Dan O'Keefe, we surveyed several national healthcare organizations to give us some data from their membership with regards to ultrasound utilization in the U.S. And as we have found in low-risk pregnancies and some plans, there was a plan that included more than 60,000 low-risk pregnancies, and they defined low-risk really well by excluding all high-risk indicators, making sure that all these pregnant women were delivered not by maternal-fetal medicine specialists, but by general OB-GYN physicians or family medicine physicians, excluded any preterm birth or Medicare and Medicaid, Medicare or Medicaid insurers. And what they reported to us that the average number per pregnancy of ultrasound that is being used in obstetrics is somewhere between 4 to 5 per pregnancy. And we got information from another large insurer that included more than 200,000 lives that also provided us with very similar numbers. So we feel that ultrasound utilization in obstetrics today is high. It certainly exceeds recommendations of existing national guidelines. So the national guidelines as exists today by the American Institute of Ultrasound and Medicine indicates that outside of indications, outside of pregnancy indications and low-risk pregnancies, it's recommended to do one ultrasound in the second trimester for anatomy assessment. But as I have mentioned, the average number or the median is about 4 to 5. And that's what most low-risk women get in the United States. So given how common ultrasound utilization is in the U.S., it's really important to make sure that the quality of that ultrasound is high to ensure adequate prenatal care and ensure adequate utilization in practice.
Thank you, Dr. Abuhamad. So already I'm learning something and revealing my lack of knowledge about the current practice of obstetrics and gynecology ultrasound. I did not know there was quite that much utilization. And I guess I'll reveal a little bit of another bias, which is I often communicate with my obstetrics and gynecology colleagues about ultrasound examinations and often bother them for the latest and greatest and also interpretations. So this next question I think is very important for me and I'm sure other providers out there, and that is what is the current quality of obstetrics and gynecology ultrasound in clinical practice?
Yeah, very good question, and we don't really know the answer to that well, but we have some information. First, let me step back and state that performing quality in obstetrical ultrasound is difficult because ultrasound in obstetrics is commonly performed looking for normality, right? So we do an ultrasound to ensure that the pregnancy is okay, that the fetus does not have congenital malformations and to date pregnancy. And because the incidence of congenital malformations is rare, 3 to 5% of the major malformations. So you can actually perform an excellent ultrasound with regards to detecting malformations, frankly, without turning the machine on in 95% of the time. So this is why over time we've struggled with trying to understand what is the quality of ultrasound that is being performed in the US. But we have some data, at least from the AIUM accreditation, that states that at least in some settings, that the quality of ultrasound could be substantially improved. So when we looked at the AIUM accreditation process several years back, this was in 2004, we looked at all the ultrasound, the AIUM accreditation is still today in most states, with the exception of Virginia, it's not a mandatory requirement for reimbursement. In the state of Virginia, it is with regards to Anthem insurers. So we assume that practices that made the decision to seek ultrasound accreditation really have value quality of care and want to comply with existing guidelines. So we reviewed from 2001 to 2004 all the ultrasound practices that sought accreditation with the American Institute of Ultrasound and Medicine, and we looked at their case studies that were submitted at the time and compared those, graded them with regards to the existing national guidelines. And we were surprised to see that only 40%, actually only 60% of those practices we're compliant with the existing guidelines for the performance of the OB and GYN ultrasound. So that states, in other words, 40% of ultrasound practices were operating below the minimum AIUM standards and guidelines for the performance of ultrasound exam. So that was an indication for us that probably we are underperforming with regards to the ultrasound, and there's a lot of room for improvements. When we look for studies that look at fetal malformations, especially when you look at congenital heart disease detection, there's a lot of variations in the US alone, let alone the world with regards to that. Experienced centers detect a lot of these malformations, and if you look at counties that don't have tertiary centers in them, you would see that prenatal diagnosis of congenital anomalies could be less than 50%. Cardiac anomalies could be less than 30%. So I think I could summarize by saying there's a lot of room for improvement, and the quality could be better, and I think it's upon all of us to work really hard to improve the quality of the OB-GYN ultrasound in the United States and abroad.
It's definitely somewhat a surprising response. I think one thing I hear that's for me is reassuring is that the bar seems to be set adequately high enough that not everyone automatically clears that bar, and it takes quite a bit of work. It sounds like we've covered a little bit of question 3, the next question we were going to ask, which is prenatal ultrasound performed optimally for the detection of fetal malformations or fetal growth abnormalities? And Dr. Abuhamad, you quoted some statistics. Is there anything else to add about that? Perhaps some future thoughts or any projects that are underway to improve or change the rates of accurate diagnosis?
Yeah, so I think what drives the detection of ultrasound for congenital anomalies are really ultrasound, training and education of physicians and sonographers performing the ultrasound examination. And I think this is one of the main reasons why the task force was assembled, to really look at how could we improve ultrasound training and competency assessment at the level of the trainees, because I think the trainees are captive audience because they are there and they are in the middle of their training, and could we impact that for the future? The fact that there are so many variations with regards to fetal malformation detection, I think speaks to the fact that this could be improved, and there need to be improvement, because you would not expect variations beyond of such magnitude performing the same ultrasound study on the same population and getting different results. And a big part of this probably related to quality of the ultrasound examination. Briefly, with regards to fetal growth abnormalities, we struggle a lot with our ability to detect, and this is universally really, ability to detect the small for gestational age newborn after birth. And what we call fetal growth restriction beforehand may not correlate with this. And large studies have shown that we miss a lot of small for gestational age newborns by doing ultrasound, even if we universally do ultrasound in the 3rd trimester. And in many occasions when we make the diagnosis of fetal growth restriction, that does not automatically equate with a newborn that is small for gestational age. So there's a lot of room for growth and discussion with regards to that topic also.
Thank you, Dr. Abuhamad. My next question, and I think this leads into our current discussion very well, and also I guess I'll share my view, which is I imagine that it's easier to do high-quality obstetrics and gynecology ultrasound in major academic medical centers, but maybe harder elsewhere, and hence the question. Can we improve on the current quality of obstetrics and gynecology ultrasound in clinical practice, the practice that affects everyone?
Yeah, the brief answer to this question is absolutely yes. And the data that exists in the literature points to that. So I'll give the example of the AIUM accreditation again. When we went back and looked at those initial practices that applied for accreditation, and we looked at how did they comply with existing guidelines, national guidelines with regards to the performance of the exam, the ultrasound exam. And as I stated earlier, we noted that about 40% were performing below the minimum requirements for that ultrasound exam. And then we went back 3 years later. You know, the AIUM accreditation cycle is 3 years, and then every 3 years practices have to resubmit ultrasound studies, case studies for review, for peer review. When we looked back 3 years later for those practices, we actually have found that the effect of the ultrasound accreditation had resulted in an improvement in their scores when they came back. So it appears that if we, at least the accreditation part there had a very positive effect on those practices when they came back. And not only when they came back, because you could criticize and say, well, maybe they've learned what do they need to submit. But when we compared the reaccreditation cycle group with those that are coming into accreditation at that time, we still found a significant effect of the reaccreditation. So ultrasound accreditation allows you to, probably because of the peer review, because of the review of the guidelines, elevates the standards in your practice. There are other studies that have been really impressive with regards to that. There was a study that was done in one ultrasound unit, taking their 13 sonographers and mandating an electronic checklist on those sonographers with regards to all the elements that need to be seen as part of the standard basic obstetric ultrasound examination. And they did a quality assurance review on a quarterly basis, and the sonographers knew that they were going to be assessed on a regular basis. The impact was incredible, and the impact showed that going from a baseline 49% average compliance with the standard to a 97% after this has been implemented, and this was attained after 4 quarters. Another important aspect that we see, that instituting standardized approach to the ultrasound exam, mandating training and quality assessment improves outcome. We have data from large countries in the Netherlands and others that have wide network of training within that country. What they have done over the years is mandating a level of competency and instituting surveillance to the ultrasound exam, making sure that the ultrasound examinations are reviewed on a regular basis. Significant improvement in detection of congenital heart disease from a total of 35% to 60% after this has been instituted over a short period of time. This is from 2007 to 2012. So data indicates today that quality and training and competency assessment is really important. Developing a system, a checklist, or a system that sonographers and physicians comply with, and making sure that there's reviews, ongoing review, tend to elevate the standard substantially of the ultrasound examination, which is really incredibly important, because it shows us that there is substantial room for improvement of how the ultrasound examination is done.
Dr. Abuhamad, it's amazing to me always to hear repeatedly how important quality insurance, quality improvement, and proper planning is when it comes to ultrasound education and practice. Leading into the next question, this is something that I experienced 20 plus years ago, which is that people tended to come up with a number. We were forced to come up with a number of ultrasounds that our trainees, our students, our residents, and fellows should perform of a particular exam in order to be considered competent. And the question is very much on target with that. Is there a target number of ultrasound examinations that establishes competency?
Yeah, really very important question, and very relevant question to the discussion at hand. Is there a target number? We don't know. And it varies based on individuals, right? So some individuals maybe are more ultrasound inclined and tend to learn much faster than others. But the real question here, is there a minimum number that you should do as part of competency? There was a study that was done at Duke several years back by Dr. Barbara Herzberg, that she looked at how many ultrasound examinations are required for competency of her residents when they joined the department, and that included 10 PGY1 residents. And they did a very thorough evaluation of the studies. They let them scan. After they trained them initially, they let them scan independently. And then they used the standardized checklist to assess their competency on the ultrasound examinations. And I could tell you, even after 200 ultrasound examinations that were done, the mean percentage of anatomic landmarks that were depicted of the 100% was only 56% after 200 ultrasound examinations. And the number or the percentage of cases that were deemed that they passed, meaning that everything that was you as a trainee supposed to document and show, how many of those cases after 200 ultrasound examinations, only 16% met that criteria. So that study was an eye-opener because it shows that you probably need more than 200 cases. When you look at what is required by the AIUM from somebody finishing a residency training in OB-GYN, it states that you need 300 cases, and that number was pulled without, as this was a consensus expert, without really any scientific basis for this. So I don't know what the real number is. What I know is at least 200 to 300 cases need to be performed, but it's really more important than having a specific number is having a way to assess competency. Because, for instance, how many ultrasound cases you need to be competent in measuring a biparietal diameter? Rather than saying, I want to see 200 cases, well, maybe the 200 cases has a systematic error in them, and you're measuring from a coronal plane every single time. There should be a competency process where you submit cases, and they are reviewed and graded, and feedback is provided to you. And then from that aspect, we can determine that you've met competency when you consistently are submitting those cases. And the task force that was put together, we had a lot of discussion about this, and we decided that, and I'll show you later that number 5, the 5 cases submitted, has some validity to it, that you need to submit 5 cases that meet competency for a measurement of a BPD before we say that you are competent in BPD measurements. The data that exists now from graduate medical education, if you look at the case logs reports from the ACGME, for instance, for obstetrics and gynecology, for 2016, the 50th percentile for obstetrical ultrasound in the country was 94. And so you could see, and the minimum requirement is only 50. So you could see that this is something we need to work on and discuss and see is 70 cases or 95 cases in 4 years of residency training enough for you to become competent? I'm not sure, but I think what is more important is you need to meet these criteria based on the competency elements that we've developed as a task force to deem you competent. And I think that is the more important aspect of competency than coming up with a number per se.
Insightful answer. Thank you very much, Dr. Abuhamad. It kind of leads me to a question that's not necessarily scripted, but one I feel I must ask. When training residents and fellows, I felt that sometimes I could pick out the residents and fellows that would need a little bit of extra time and perhaps more scans to reach competency. And I could do it on a small scale. But do you feel, and did the task force struggle with the question of how do you scale that competency? How do you account for the residents that might take a little bit more training? Was that a topic that came up? I'm just curious.
Yeah, absolutely. It is a very important topic because we have variations, with regards to our ability to learn ultrasound, but also more importantly, our ability to perform ultrasound. And I think after much discussion and debate, if you come up with a certain number, and if you say, okay, you need 50 BPDs, I'm going to use the BPD example again, you need 50 BPD measurements for me to say you are competent. Well, and somebody who is more inclined to learn ultrasound because of their, how they are built internally, how their brain is built, their hand-eye coordination and so forth, their ability to see, in 3D, their their knowledge of the anatomy and so forth, yeah, maybe they need 20 rather than 50. And somebody else who is not built that way may need more than 50. So to get away from this, knowing there's variability in skills of trainees coming in and sonographers and sonographers, we've decided that let's make sure you are competent. Let's make sure you submit 5 images of a BPD that show competency. So you've learned the text, you've spent the time working on the curriculum to understand what is competency in ultrasound, and then you're going to submit those images. Once we see 5 images that meet the criteria as they are defined, then we could say you are competent. That does not mean you're fully trained. That means that you can measure BPDs, and over time you can refine that skill and become more and more competent over time.
That answer for myself, I know I was at the upper end of numbers when I was struggling to learn, so I'm glad to hear that there's some flexibility and recognition of that. And that leads me into our last question, which is how many ultrasound examinations are performed by residents during their training right now?
Yeah, and from the data that I alluded to from the ACGME, we could not find data. The data related to the radiology practices are not made available, are not publicly available. For the data related to the obstetrical practices, the ACGME requires a minimum of 50 ultrasound examination to CANA during your residency program, 50 OB and 50 transvaginal ultrasound. Now, transvaginal are not defined as gynecology or they could be cervical length. So they are not defined either or. So from the data that exists from the ACGME case logs, as you know, residents have to submit their numbers to the program they are at, program directors, and the program directors need to upload them nationally. As I mentioned, the 50th percentile for a 4-year residency in OB-GYN in the United States was 94. So, and then the 95th percentile did not exceed 200 scans. So at least based on the data that are available today, we feel that the average student, resident in an OB-GYN practices performs in their 4 years of training about 100 ultrasound examination in obstetrics. Is that enough for training? It's hard to say. The data that exists today states that you probably need more based on the studies that I've mentioned before. We shied away from putting a number because of lack of scientific evidence that a number makes sense. We wanted more to ensure you're competent by showing competency, demonstrating competency, which is the same way now many things are done related to your training in OB-GYN, so, and radiology for that matter.
Thank you, Dr. Abuhamad, for tackling these questions and giving us so much insight. At this point, we're reaching our question and answer session with the audience. And in the room.
Mike, let me state before we
Sure.
go there, I wanted to expand a little bit on the task force and how did we put the task force together and what are the components of it. I know it's not in a question, but I think that will give the audience some information about how the task force came together to create the curriculum and to create the competency. So the task force was originally put together by the AIUM, but also included membership from several organizations and societies, such as the Society of Maternal Fetal Medicine, the American College of Obstetricians and Gynecology, the American College of Radiology, let me get to that. Yeah, here you go. The American College of Osteopathic Obstetricians and Gynecology, Society of Radiology and Ultrasound, and International Society of Ultrasound and OB-GYN. I want to put in a special thanks for Kathy Minton. Kathy Minton is the AIUM Clinical Education Coordinator who really was instrumental in getting us all together. This started in 2015, in August 2015. Several meetings occurred throughout the year, and a face-to-face meeting occurred on March 18, 2016 to finalize the task force work. We decided early on to divide the task force into two halves, two subgroups. One to work on the cognitive part of the curriculum. This is what you need to learn, what are the lectures you need to get, what are the topics, and what are the objectives of such. And the second one is the competency curriculum. Here in the competency curriculum is what are the competency things that we need to measure and you need to submit images for, and how do we grade you for that. So for instance, let me give you an idea of what the curriculum would be for a first year level 1 or year 1 resident in obstetrics or in radiology. You need to learn the basic principles of medical ultrasound, the basic characteristics of the ultrasound exam, the aspects of the ultrasound exam itself, learning the equipment, the knowledge. You need to learn ultrasound in the first trimester, second and third, how to evaluate twins, how to evaluate placentas, and amniotic fluid assessment. So this does not mean that you need to learn everything related to ultrasound. Within each component, there are variations of things that you learn throughout the years. For instance, I'm going to take evaluation of multiple pregnancies or twins, and I'll tell you in year 1, for instance, you have to learn, explain the role of ultrasound in the diagnosis of twins, recognize and describe how chorionicity is determined in multifetal pregnancy, right? This is recognition and description, this is not performance yet, and recognize and describe amnionicity in monochorionic multifetal pregnancies. The second year, you start to build on this. And the second year, for instance, if I take twins and twin gestation in the second year here, you start to describe methods of determining twin placentation by ultrasound, the role of ultrasound in follow-up of twins, the role of ultrasound in serial evaluation of discordant twins, the role of ultrasound in the evaluation of twin anemia polycythemia sequence, and so forth. So you could get the gist of how this is done. It's progressive year over year, and we built a 4-year curriculum that residency programs could take and say, I'm going to adapt it that way, or you know what, I want to give a little bit less in first year because of how my curriculum is designed, and I'm going to give a little bit more in the second and third year. This was a consensus-based from a task force that included membership from OB-GYN, radiology, education specialists that came together to develop this. We left a lot of leeways within the task force also with regards to, do you need to obtain these images when we talk about competency yourself, or somebody else could obtain them for you? So we anticipate if you are in a radiology practice where you rely on sonographers in your ultrasound examination, then you can have your sonographers obtain those images. You need to know what are the components of each image. So you need to review it, make sure it's the right image, then submit it for competency assessment. The competency part, we've developed about 37 competencies that are spread over 4 years. So the first year, in the first year, we expect by the end of the first year that the first year resident would be competent in measuring the mean sac diameter, crown rump length, fetal presentation, fetal extremities, BPD, head circumference, abdominal circumference, femur length, perform a biophysical profile, assess fluid, and measure the maximum vertical pocket. So if you think about this, you can group them into 2 main categories. We want the first year resident to know to do basic biometry and to do a biophysical profile. Why we feel that this is really essential in their training early on, and also as they are on labor and delivery, for instance, on the OB-GYN side, they're doing a lot of estimated fetal weight there, they're doing biophysical profiles, and so forth. In the second year, the competency curriculum states that we want you to know how to measure the cervical length, how to measure endometrial thickness on GYN ultrasound, uterine measurements, ovarian measurements, and perform a transvaginal pelvic ultrasound to assess the uterus and the ovaries. That's the second year competency. So it's here cervical length and basic gynecology in the second year. In the third year, we start getting into anatomy. Here we want the third year resident to become competent in doing a basic fetal anatomy. Now, This basic fetal anatomy is really reflective of the basic obstetric ultrasound examination as currently defined as a national guideline by the AIUM, ACOG, and ACR. So we're not adding anything that is outside of that basic obstetric ultrasound examination. Looking at the head, you do lateral ventricular plane, BPD plane, posterior fossa, upper lip and philtrum in the face, 4-chamber view, LVOT, RVOT, and abdominal circumference. And then you're going to look at the kidneys, the cord insertion in the abdomen, number of vessels, look at the pelvis for the bladder, and then spine, longitudinal, and axial, and how to write a report both in obstetrics and gynecology. And in the 4th year, we expect that you've really gone through all these competencies. Now we want you to get a facial profile and to do amniocentesis to assess fetal lung maturity, which is part of the requirements for ACGME for OB-GYN resident training. We've had some additional competencies. If you are in a residency program, you want to do more, and we've listed some of those. I don't want to go through them because of the interest of time. I'm going to say 2 or 3 things, then we open it for question. How did we build these competencies? So next to each competency, there's a representative ultrasound image that we think is the right image for that competency. I'm going to use femur length as an example, for instance. And then we've developed, based on the experts on that task force, what are the components of this image that we want to see to grade that image. For instance, for the femur length, we said the focal zone should be at the appropriate level. The image should be magnified. The whole femur diaphysis should be imaged. Ultrasound beam should be as perpendicular as possible to the long axis of the femur. The caliper should be placed at each end of the ossified diaphysis. And you should measure the longest visible diaphysis in the image, and any spur artifacts on the ends of the diaphysis should not be included in measurements. So we have 7 criteria. And we said if you need to submit images, and the images should have a passing grade of 70%. So you should meet 5 or more of these criteria when you submit the images. Then we said there is one criteria in this image. If you don't display, you're going to fail this image. For instance, if you did not display the whole femur diaphysis in the image, if your image was oblique, that you've seen part of the femur, even if you've had everything else there, then we're going to fail you on this image, because these are like really important. Like for the BPD, if you don't have an axial view or a transverse view of the head, right? That's a fundamental problem. And then 3, how many images you need to submit. We decided to have 5 passing images to submit. So for the femur length, for instance, we want the resident by the end of their 1st year to have submitted 5 images that score 70% or more on the femur length, and then you got to check that you passed the femur length. Where does the 5 come from? Consensus of the team, but also there's some articles that have shown that when you reach 5, especially on simulators, when you reach 5 or more repetitions, then you start to perform very similar to the consultants and to experts in that sphere. So there's some evidence to suggest that 5 is probably the appropriate level. We also stated in the document that as knowledge is evolving, and we're hoping that the societies will put money into research into this aspect given how important it is, we will learn more about competency. And we may adjust this. Measuring a crown lump length, for instance, at 10 weeks is probably much simpler than measuring a BPD. And do you need 5 of each? There's evidence that states today that 3 measurements are enough on simulators for crown lump length, whereas you need probably 5 on BPD. So I wanted to share with you how this document came about. You may ask, when is this document going to be available? It was officially released 2.5 weeks ago at the AIUM forum that occurred in Boston. I'm not sure if it's on the website. I think it's going to be published. We are writing the manuscript now to be published in the Journal of Ultrasound and Medicine and in the American Journal of OB-GYN. So we're hoping to get it out there in the next couple of months, and then we will be open access, widely available to everybody. The document contains in it all the details that you need with regards to the competency, the 37 competencies that I mentioned, and also has in it all the curriculum objectives that you need for residency training. Sorry that I interrupted, Mike, but I wanted to give an overview of the task force results before we get to the QA session.
Not at all, Dr. Abuhamad. In fact, I'm not sure I could have asked for a more perfect interruption. Those were all details I was dying to ask you about, but was hesitant to go off script for it in case it was not public yet. So that was just perfect. As I mentioned, at this point, we'd like to go to the question and answer portion of this session. There is a chat or question box on the right side of your screen where you can type in your questions. This is also a great time to give us additional feedback, any information you'd like to share, because we would love to know what we can do for you in the future to improve our educational offerings. And this is a great time to share. We may not be able to get to everybody's questions, but we'll do our best. And we'll start with the first one for Dr. Abuhamad. And the question is SonoSim going to develop a comprehensive module for assisting in developing competency for OB measurements such as crown rump length, biparietal diameter, abdominal circumference, and femur length?
So at least my understanding that this is something that SonoSim is looking at very carefully. And as you know, SonoSim is actively has developed a very comprehensive module on obstetrics, is finalizing a very comprehensive module on gynecology also that will be available, I understand, fairly soon. So in keeping with all this, I think it would make a lot of sense for SonoSim to develop ways to do competency assessment based on the task force results. I'm not in the planning team for SonoSim, so I leave it up to them to make that decision. But from a task force perspective, there was a lot of discussion about how important is the role of simulation in OB-GYN ultrasound training. And the reason that was discussed and stated in the document is because not only we realize that simulation is very powerful in ultrasound training, but also there is a little bit of gap that we have identified in the availability of trainers across the country in many residency programs. So having simulation as part of this, not only that, but simulation with content that is embedded within would really go a long way to bridge that gap with regards to the availability of trainers that are really able to provide competent training to residency programs. So I hope that we will go that way with SonoSim. I anticipate that we will, but it's really a very important question.
Something to look forward to definitely in the future. The next question I'll paraphrase and add my experience to it as well in the form of the question. And that is for more senior practicing physicians that want to learn ultrasound or improve their skills, what are some good ways to do that without the additional stress of, or maybe embarrassment of showing to younger colleagues or trainees that you could use that freshening up? And I've experienced this with my fellow faculty that really wanted to learn, but their request from me was, how do I learn somewhat privately so that the residents, the students, and others don't necessarily see me struggling with something that they know? What are your thoughts about that? Is simulation a part of that or not really? How would one go about tackling this topic?
Yeah, and I would say it's a very important topic, and there's certainly a need to do so. And I would say, based on my experience in mentoring other faculty and senior fellows in this, is there are two aspects to this. First, simulation is really, really important because you can develop your hands-eye coordination, you know, through simulators that really allows you to expand your skills in probe manipulation, in how the image is displayed, and what you see when you turn the probe right and left, and so forth. So that's really a big part of this. The other part of that is doing the actual ultrasound examination per se. Many of us have sonographers that work with us. So going after the sonographer after the study is completed and taking it piecemeal. Let's say I'm going to practice on the fetal head in obstetrics, for instance. So today I've read about it. I've done some simulation about it. And what I'm going to do today is I'm going to scan 10 patients after completion of their ultrasound, and I'm going to get a BPD and a head circumference. I'm going to look at the anatomy and complement this with your knowledge, what you've learned and what you've done on a simulator allows you to start building your skills. Ultrasound is inherently a difficult imaging modality to do. That's why simulation is really important and training is really important, but it requires time. It requires time and effort. So, but having the simulator you can work on at home is really important, and having the ability to scan real patients is also really important. So I think using this combination with a lot of reading, right? Reading ahead of time and whether it's embedded in the simulator itself, the knowledge, or you can read from ultrasound textbooks, allows you to start understanding when I get an axial view of the fetal brain, where am I in correlation to normal anatomy? What are the structures that I see? Why they are anechoic or echogenic and so forth? That I think is really important in starting to building your ultrasound knowledge. And then once you get to that level, it's easier to build on that.
Thank you very much. It definitely makes me sometimes wish I was born a couple of decades later to have benefited from all these additions to ultrasound education, simulation, a structured curriculum, and not having struggled. But somebody had to do it, I guess. We do have another question for you, Dr. Abuhamad. This looks like a very good one. And it says, did the Residency Ultrasound Education Task Force have any discussion about setting aside time for ultrasound rotations throughout the obstetrics gynecology residency, for example, sometime every year for the residency, so one portion during each of the 4 years?
Yeah, excellent question. We have looked at surveys as part of the, I did not have time to cover this in this webinar, but as part of my review of what exists in the literature and in preparation for the work on the task force, I've looked at surveys that were done by ACGME and by others. Dr. Wesley had done a survey several years back on ultrasound training and residency programs. So there are a lot of variations. The average time is 4 weeks of a rotation in ultrasound, but then probably most residency programs, I think if I recall more than 50% of residency programs, do not offer any structured ultrasound training for residents. As you know, with the expanding demands of knowledge, of surgical procedures that need to be taught, and with the limitations and time that came about with the 80-hour weeks and others, ultrasound has been squeezed out of the curriculum in many programs. We feel that the task force will probably help re-energize and refocus this and show how important is ultrasound both in OB and in gynecology practice today. It's really integral to what we do, and every single physician in their practice of OB-GYN will be heavily employing and dependent on ultrasound in decision making. There are several aspects that I think would help this. I think first of all, simulation will play a big role, as I mentioned, because it's much easier to learn from simulation. It's much easier to track progress of residents in simulation for program directors, and more importantly, the ability to have embedded information within the simulation can really almost obviate the needs for expert faculty in your program. So residency programs will be well served by looking at simulation and incorporating simulation in their practice. Two, I think by bringing this information in an organized fashion and in parallel to the task force that I have chaired on ultrasound training and competency assessment, there's another task force that is developing lecture series on various topics of ultrasound. So now programs have the ability, and that should be done in the next 4 to 6 months. So programs will have the ability not only to have the curriculum, but also to have matching lectures in ultrasound that they will give at their academic time for their residents. So that's really, really important, because then you are not asking your faculty to prepare these talks. They're already been prepared by experts in their field, and they're going to be made available to all the residency program. We are currently working with CREOG and others to make that a reality. So I personally believe having an ultrasound rotation probably in the first year is really important because, medical students, especially if you don't come from a program where ultrasound is embedded into your medical education, and just a shout out for Mike for having, leading internationally those efforts to incorporate ultrasound in medical education. If you come out of a medical school that does not have ultrasound, you're going to struggle initially, and having a rotation, even a month, more recommended 2 months, to do so in the first year will go a long way towards that training. But for those programs that can't afford to have that for whatever reasons, I think simulation along with the lecture series will and having a standard curriculum and a standard way of doing competency, and if indeed we get to a point where competency could be done remotely through simulation, I think that would benefit a lot of programs across the country. Now, I will add a note that, even board exams, the American Board of OB-GYN and others are starting to look at ultrasound very seriously and starting to look at ways to do hands-on scanning at the time of the oral board exam to assess competency. I think that's going to push a lot of residency programs to start incorporating ultrasound in their training.
Incredible to start seeing hands-on testing during board examinations, but really makes very good sense. Just one more question, it looks like, and this is also directed for Dr. Abuhamad. Let me just get to the front of the question. The question is as follows, and I'll try to paraphrase. This is from a director of an accredited ultrasound program at a community college, and they have seen a trend in their geographic region for a reduction in clinical sites available for training, especially in maternal fetal medicine practice space. And one of the challenges is that it's a very hectic clinical environment and the standards are very high, but yet this is professional experience that's required for sonographers when they're obtaining training. And this could be negative for long-term outlook in terms of quality training for sonographers that find this to be a challenge in their training place. Could you, Dr. Abuhamad, comment on how we might reverse this trend in the near future, hopefully?
Yeah, thank you for pausing that question. Very important and timely question, because although the struggle noted, as I understood from the question, relates to sonographers having clerkships, availability of sites for their clinical training, and how important are sonographers, and really the quality of ultrasound is critical nationally. But also this is an issue that we are facing now for medical students placements. As you know, with the expansion in the medical student class, there has been limited availability of clinical sites for rotations, let alone ultrasound, but other clinical rotations. It is really, really important as many of us are leaders in our community and regionally to really always push for expansion or sustainability of clinical sites for sonographers training. Because at the end of the day, the quality of the ultrasound that is done nationally is so much impacted by sonographers training that exists, even though the task force primarily was intended for residency training, but the curriculum and the competency assessment can be absolutely used for sonography training. And I would encourage the person who posed the question to look at this and try to incorporate that in their sonography training in OB-GYN for their sonographers. It's very important for us to expand those sites, because I think what you see is the clinical sites have been really very busy with a lot of students, that because many of the medical schools across the country have increased their class size over the past 10-15 years by 15 or 20% or more. So there are more students that are available or around in these sites. Now we talk about having residents involved in there. There's a lot of visiting students, visiting residents trying to get residency programs. So it's a very crowded environment. But I think it's really important for the sonographers to play a leadership role in that and really make sure that they keep the door open for student sonographers to come in. I mean, we've always, in my unit here, we have a large ultrasound unit. We have more than 16 full-time sonographers that work in the unit. We've always opened the door for our student sonographers because we felt this is essential for us long-term from a selfish aspect of things, frankly, because then we can train the sonographers, and many of them find their ways into our laboratory later on, and I think it's really critical to get them trained. So I said a lot just to say that as physician leaders in our communities, we really have to note how significant that is and to work with the sonography schools. And I would encourage the person who asked the question to reach out to the leadership of that, go meet with the director of the maternal-fetal medicine practice and explain to them how important that is, and ensure that the sonographers will probably not take space in there. They will work with one sonographer, devise it in a way that's not going to be in the way of the practice itself, and potentially can provide a lot of support. I would state that my daughter is a sonography student now, and she is in her clinical rotations. And I see that as really a very important aspect of her professional growth and knowledge in this field.
Dr. Abuhamad, it's always amazed me how important education is, how critical it is to patient care, to the future of ultrasound, but yet what a challenge it is as far as ongoing nurturing of the education process, continuously looking for new and innovative methodologies and also venues. Thank you for those comments.
Thank you.
At this time, we're at the point where we will close out our webinar. Please direct any questions we haven't been able to get to info@sonosim.com, and they will be answered after the webinar as soon as we're able. On behalf of Dr. Abuhamad and myself, I would like to thank SonoSim for sponsoring this webinar and would like to thank you for your participation, and please enjoy the rest of your Thanksgiving weekend. Thank you again.
Thank you.